And good morning, everyone. It's great to be with you. I really enjoyed the panel discussion. I was able to hear a bit of it. And so definitely asking all the right questions. And what I'd like to do today is to provide you with the sort of financial insights into this. How do you best leverage and move these things forward? So let's talk a bit about that. Just a bit about UPMC to start. UPMC is about a $24 billion. It is both a provider and an insurer. And so around 20 plus years ago, we started a health plan that's grown significantly. Right now, it's got about 3 million members. And it's about 50% of the revenue of UPMC comes from the insured side. And that insured side provides about 40% of the provider revenue. So it's truly become a capitated entity for about half of its revenue. So it's allowed us to evolve and kind of learn and be on this journey from volume to value. So I want to share some of those experiences with you. So we were a pure provider 20 plus years ago. And so it was really all about top line revenue enhancement, and quality was just the numbers that we reported to the governmental entities. And so we've moved this thing forward now. And truly on our quality journey, we're beginning to think about value and not volume. And, it's great to hear everyone speak today. And the research that I've done on the health system in Singapore, I've been very impressed with what you're doing. I absolutely believe you have the right strategy with the three beyonds, healthcare to health, hospital to community, and quality to value. So it's the right strategy. The question is, do you have the right financial incentives in place to be able to implement that strategy successfully? And I really want to drive home my point is the keys to success in this journey to value is that you have detailed cost information around the activities in the country, what's happening in your hospitals and with your physicians. Do you have detailed information about outcomes and around variation? Very critical to success. And then finally, and I heard this from a number of the panelists several times, the reimbursement system that you have in place is absolutely critical. You are going to get what you are incenting people to do, right? We all do what we're paid to do. We do that as individuals and we do that as organizations. So what you'll hear today is that it's critical for you to align financial incentives to achieve the outcomes that you're looking to achieve. So this slide shows the continuum that I call it in moving from pure fee-for-service over to fully capitated, full capitation. And as you can see, the amount of risk that's transferred over to the providers varies significantly. So in a pure fee-for-service environment, there's really no risk at all around the population's, the cost of delivering healthcare, and in some cases, even the outcomes. And that changes significantly as you move across the continuum to full capitation. And as I said, as an insurer and a provider, we're fully capitated on a piece of our business. We have traditional fee-for-service on some parts of our business. And we have other parts of our business where we've become and started to utilize episodic payments, such as bundles. And I'll talk about a bit about those as well later in the presentation. So this is just to ground you in the economics and the differences between fee-for-service, which you see in the left-hand column, and the far right, which is where the provider is fully at risk, or in the United States, where an insurer is involved. An insurer has full risk for cost and for the population. And if you look from top to bottom, there are three areas of waste. And this is a slide that I borrowed from my colleague, Dr. Brent James. So the majority of waste in healthcare is in utilization, pure utilization, around 45%. The second large bucket is within case utilization. And then the third and smallest bucket is just pure efficiency. As a fee-for-service provider, you are actually harmed if you utilize less, if you have fewer surgeries, fewer inpatient admissions. And really, you only are rewarded financially for efficiency. And that's much different as a provider. As a provider that is at risk or capitated, or a traditional insurer where they have full population risk. And so with all of those reductions in waste, reductions in utilization, within case utilization, those all accrue financially to the benefit of the provider that's fully at risk. So the point I'm trying to make is it's very difficult for a traditional fee-for-service provider, hospital, GP, specialist to move from fee-for-service to capitation or to value. This is just a drill down on that to show a financial example. So this would be, for example, a hospital in the US, which has significant indirect or fixed costs, about 70% of the costs in the infrastructure, the buildings, the IT, the baseline level of staffing. Those costs don't move with volumes, and only about 30% are direct or variable costs, which move with volumes. So if revenues were to go down, if volumes were to go down by 5%, expenses would only go down by 1.5%. So there's a 3.5% hit to the bottom line. And we saw this in the US with the COVID pandemic and the reduction in outpatient procedures. So there were significant reductions in volumes and revenues to providers, and there were significant and serious financial implications as a result of that. And really the only entities that performed well were those that had capitated contracts, either physician practices, which had capitation, or payer providers like UPMC, like Kaiser, like Intermountain, that weren't fully exposed to the reduction in volumes under a pure fee-for-service environment. So what were some of the lessons that we've learned over time at UPMC? And I'd like to share some of them with you. As I said, reimbursement absolutely impacts behavior. So it's great to have an aspiration like you do in Singapore with the 3 Beyonds, but unless you have a reimbursement system that supports that aspiration, it's very difficult to implement change. And I'll use the example at UPMC with a project you may have heard of, but it's the Medicare CJR initiative in the United States. That's the Comprehensive Care Joint Replacement Program. And really what that was is a bundled payment that was made for hip and knee replacement surgeries in the United States. So it was both the hospital utilization and then 90 days of post-acute care. And under the old fee-for-service model, everything was disaggregated. So you had the physician, you had the hospital, and then you had the rehabilitation provider. And each of them were paid independently. So the care was not connected. So of course, what you had was higher utilization of post-acute, inpatient rehabilitation stays, and very little measurement of outcomes. It was really about doing the procedure and getting paid. UPMC was a participant in this CJR bundle, and what it changed to was a one bundled payment and a coordinated level of care between the physician, all of the physicians that were involved, the primary care physician, the specialist, the hospital that was involved, and then the post-acute rehab provider. Once they were all working together under one payment, they had shared financial responsibility. We saw a reduction in unnecessary utilization. We saw a significant reduction in post-acute care and unnecessary post-acute care, standardized pathways, improved patient satisfaction, and then most importantly, a reduction in the cost to the government, to the Medicare program. Double-digit cost reductions were seen as a result of this bundled payment. So that is to prove my point, or to drive home my point, is that reimbursement absolutely impacts behavior in healthcare and the practice of medicine. So on that journey, once you start down the path for value, you will start to lose volumes. And how do you then finance that transition from volume to value? Well, you need to have you need to increase the volumes, offset the volumes by having more patients, seeing more patients, so the utilization decreases, but you're now able to see more of the population. So we're going to reduce utilization, but we're going to offset that with more covered lives and higher volumes and more patients. And I know you have capacity issues. You mentioned them during the panel discussion, and this is the way that you fix that. You actually create capacity in your existing infrastructure. So you leverage that fixed cost infrastructure that you already have by increasing the number of patients you can see in the same facilities and with those same physicians and infrastructure, because you're utilizing less on each individual. Very important is that everyone must be capitated in the same way. So the incentives must be aligned. Sometimes in the US, we have hospitals that want to be capitated. They have a strategy to be capitated, but the individual physicians are still being paid on an RVU, on a volume basis. So you have a strategy at a very high level that says we're going to embrace value and we're going to reduce utilization, but the physicians who are the decision makers, who are prescribing the care, are still being incented on volume. And so those two do not reconcile. So it's very important that you have aligned incentives financially. And I'd also say that it is a multi-year journey, and it requires investment. It requires a subsidy or some kind of bridge funding. And I'm actually very encouraged with what you're doing in Singapore. You have everything that you need to be successful. In the United States, we don't have that. We have thousands of hospitals with different systems, with different reimbursement schemes, with different relationships with payers. In Singapore, you have something that is, I think, very close to an ideal situation. You have a national electronic health record. You have 3 regions, so it's a manageable sized system. It's large enough to matter, but I think it's small enough that it can be transformed. But you need to have investment to finance that move from fee for service over to volume. So you're going to have to incentivize people during that transition as volumes decrease and there's potentially a financial hit to GPs or to hospitals that needs to be financed and bridged over until you learn how to do it properly and you make adjustments on the fly, so to speak. But I'm very bullish that with the right financial incentives, you can implement some of the same things we were able to do at UPMC in our journey from volume to value. So in doing that, you need to have great costing information, which doesn't really exist in many places. Healthcare costing today involves approximations and averages and allocations. And in many cases, the cost of healthcare is truly unknowable. I would submit to you that's not the case, and part of your strategy must be understanding cost and variation in your system. So what are what I call the levers of strategic cost management? It's not about just setting budgets and then having finance throw out targets for 1% or 2% reduction and then doing analysis of budget to actual variances. I'm talking about understanding resource consumption in the enterprise, resource consumption among physicians. Where is there clinical variation and why? And having true cost productivity and accountability, understanding the cost inputs and the volume outputs to measure the true financial productivity of your health system, of individual hospitals and outpatient centers and individual physicians. And there are 3 pillars to these strategic cost levers. And we're going to go through these on the following slides, but they're really around direct and indirect cost, credible and actionable data, and being integrated with your EHR. So this is an illustrative hospital P&L statement. So the point I want to make with this is I want to start by first talking about administrative costs. Too many times there's a discussion about we have to reduce the administrative burden. There's too many admin costs, whether it's IT or finance or HR or marketing. I agree. Those aren't directly related to patient care. You should do everything in your power to make sure those are as efficient and effective and productive as possible. However, they're only about 10% of a typical health system's cost profile. So for purposes of this slide, let's take that off the table for now. I will make a point that I'll come back to later, is that usually IT costs are down below in that bucket called administrative costs. And we're going to talk on the last few slides about better management of IT costs, but I would argue those need to be put back up above into the indirect cost buckets. So let's talk about the 2 buckets of clinical cost. There are direct clinical costs. These are things that are directly related to a specific patient, things like supplies, implants, drugs, blood. They're specifically related to a patient. But the majority of clinical costs, about 70% of clinical costs, are indirect. So what are indirect clinical costs? They are things that don't relate to just one patient. They relate to many patients. Things like the operating room costs, surgical services, nursing and length of stay, imaging, labs. These are areas of the health system that are utilized by physicians for multiple patients and by multiple physicians. So the point with this is a significant amount of cost. Clinical indirect costs are the majority of the cost in your health systems. And activity-based costing is the only way to know who is consuming the majority of these clinical resources. So activity-based costing is actually a very simple concept. What we're doing is we're getting financial data from the general ledger, but we're getting clinical data from the electronic health record. It is a very rich data set from the EMR and the other clinical systems. And the problem with finance people and with your current cost accounting systems is that they were developed 20, 30, 40 years ago. They were developed before there were electronic health records. Activity-based costing utilizes, it's the only costing system that utilizes the data in the clinical EHR, and it's a very rich data set. So it combines the clinical data from the EHR with the financial data from the general ledger. And this is an example of a super collider, bringing those two data sets together to give you activity-based costing analytics, very powerful analytics to understand consumption and variation within your system. So this is a slide around change management. This is a very important point. In order to affect change, improve quality, reduce cost, you can't do it at the highest level. So if you look for the definition of change management in a dictionary, or if you Google it, it says to have effective change management, you need an organizational strategy at the highest level. You have to have teams that are organized around those initiatives, but then you have to have individual actionable data. To be able to change something, you need the physicians to be engaged. The physicians are the consumers of healthcare. They are the decision makers. They're determining which supplies are utilized, which labs are utilized, how long the length of stay is. So it's not the administrator, it's not the CFO, it's the physician that we need to inform and advise on their cost. So costing must be at a patient and physician level. So we can't go into the orthopedics department and say, you need to improve quality and you need to reduce cost. Now go and do it. That won't work. You need to go to the individual orthopedic doctors and talk to them about their cost profile, about how they're consuming resources. That's how you can change healthcare and how you can reduce cost. So simply said, what is activity-based costing? If you look on the right, activity-based costing connects actions and decisions of clinicians relating to the consumption of finite resources. Resources are finite in all of our countries. So it connects the actions and decisions of clinicians to the actual cost of each action and decision. So simply said, nothing is free. Length of stay isn't free. Surgical time is not free. There are decisions that are being made by physicians, and we want to advise and inform them and hold them accountable for the decisions that they're making. So activity-based costing is systemic, it's repeatable, it identifies physician variation, it's based on consumption, not on averages, not on allocation, and it's anchored to sources of truth. It's anchored to the general ledger, which is the financial source of truth, and it's anchored to the EHR, which is the clinical, patient, and physician source of truth. So this is an example of variation, and what I'll say is variation in all health systems is hiding in plain sight. We know that variation is the enemy of quality, but it's actually also the enemy of cost. So I want to drive 2 points home with this slide. This is an analysis of lumbar spinal fusion. There were 852 spinal fusions that were analyzed. The first point that I want to make is on a surgical intervention. If you look at the very top, 54% of the cost on a surgical intervention is with direct clinical costs, and about 46% is with indirect costs. So earlier I said on average it's about 70-30. So when you add medical admissions into this, you see how that average can change, where there's very few direct supplies or implants or blood used, let's say on a medical admission. But on a surgical intervention, 54% of the costs are direct, 46% are indirect. And I want you to look at the significant amount of variation among physicians at UPMC. So between 45%, the cost of the direct clinical cost for lumbar spinal fusions were $9,950, but the variation among physicians ranged from 45% to 162%, significant variation. And for indirect clinical costs, between 67% and 184%. So as you can see, there's significant clinical variation, unnecessary clinical variation, and it was impacting cost and quality. And this is something that can be analyzed, can be improved, and it's actionable when you take this information to the physicians. This allows service line financials, so you can look literally across the health system, different locations for inpatient facilities. In the case of Singapore, you could look across regions. You could do comparisons between private hospitals and public hospitals. In this example, we're looking at service line analytics to see what's happening with the heart and vascular service line, with the orthopedic service line. But you see, we can look at the revenue, we can look at the direct clinical costs, and then we can see how these indirect clinical costs are being consumed by physicians and by service lines to come up with the true profitability of a service line. And this can be done, again, systemically in a repeatable way, and information that's available 2 days after a financial close. So you need to have timely information to impact change. And this, through activity-based costing, it's very timely information to be able to do service line analytics. So this then enables what I call strategic cost management, things like proactive pricing strategy, doing service line management, understanding clinical practice variation, taking on risk, taking on capitation. Unless you understand where your costs are, what they are, and where the variation is, it's very risky to take on any type of a risk-based reimbursement like full capitation or even a bundle. Fully integrating your physicians with other practice providers, whether it be nurse practitioners or other care deliverers, it's able to fully optimize that. And then looking at true cost productivity in your system. I wanted to end, and we're going to go to some questions in a minute here, but I just wanted to finalize this by talking a little bit about IT spending. At UPMC, we had a significant IT spend between the capital IT and the expense IT, significant, hundreds of millions of dollars. Initially, we had a decentralized IT department. So the first thing we did, we started to see that there were changes in staffing, different selections of software, and that led us down the wrong path. So we centralized IT. But it's important that even if you centralize the resources and the management, that you avoid a corporate IT cost center. So in the early example, I showed you where it was down below the line as an administrative cost, and that's the wrong strategy. You want to embed IT costs into the P&L of the hospital, into the business unit. Why? Because it makes the business unit accountable for the IT investment. If they want an IT system, if they want to make an IT investment, it becomes part of their bottom line. So they have to feel ownership with delivering on the ROI for that IT system. So it's very important. It helps to shape the demand and the consumption when, again, the IT isn't free. And it's free when you put it below the line. So again, it's done. You do an allocation based on consumption. So if you consume an IT resource, you have to pay for it. The other thing I just want to talk about, there is a whole discipline out there. You can Google this, and I'd suggest that you do. And it's called Technology Business Management. And we implemented this at UPMC, the framework, and it really helps to drive value in IT. Again, making wise decisions, making informed decisions, including the cost in the business units, P&L, so that they are accountable for the investments that they're making and the return. I'll tell you that it doesn't have to be perfect in terms of how you're allocating those costs of consumption to the P&L. Use the 80-20 rule. Get it so that it's good enough that you can make a decision, and then usually that's enough. You don't need to go into additional details or analysis. Just get it to the level where you can make a decision. I will caution you that we kept innovation, IT innovation, in a separate budget, and we did keep that in an administrative corporate cost center. Why? Because we didn't want to stifle innovation. We wanted to have some seed funding available to really take some big swings around what we're going to do in terms of IT investments. So keep the innovation separate, but keep the costs of core IT within the business unit. And then the question always comes up around return on investment and how do you measure ROI? And I would tell you that it's very difficult. I'm unlike many finance people in that I do have a different standard for ROI. And I would ask you, what is the ROI on an email system, right? If you go back to the 90s before email, and someone said, look, I'm going to implement an IT system, and you ask what the ROI was, I would hope we wouldn't have made the decision back then to not implement or not utilize email or even the internet. So IT, sometimes it's difficult to see where the ROI is, but I say it's really around, is the system being utilized? Is it improving interoperability? Is it improving quality? Is it helping physicians make better decisions? So I really look to utilization more than I look to ROI. So that's just a couple of thoughts on IT. That is the end of my formal presentation. Again, thanks for having me, and I look forward to taking any questions that you might have.
Thank you, Robert, for your invaluable insights from your presentation. My name is James Chia, Director of Health IT Policy and Governance, and I will moderate the Q&A segment for now. There are a couple of questions from the audience. Let me start off with this first one. Population health typically takes a long time to see impact as it involves behavioral change. How can we meaningfully account for the return on investment for population health innovations and preventive programs? I believe you covered this a little bit in your last slide, but perhaps you could elaborate a bit on it a bit more.
No, and I think the best proof was the panel discussion right before my presentation, where the esteemed panelists even talked about sometimes the right incentives weren't in place. And so, because again, people are going to do what they get paid to do. So this really takes a deliberate investment, I believe, by the government. So there has to be a commitment. It does not happen overnight, but I also don't think you want to say, look, this takes too long to see a benefit. You can start to see benefits in 2 to 3 to 5 years. So in the case of Singapore, I think it would be fantastic if you can look to some what I call bridge funding or a subsidy to help to finance this transition over maybe a 3 to 7 year period where you're experimenting, where you're learning, where you can reduce utilization and what that means financially to everybody that's involved, to the hospitals, to the GPs, and really hold them harmless and incent them to do the right thing. And then what you'll see is over time, you'll start to see these savings accrue. You'll start to create capacity in your health system with its physical infrastructure, with the number of physicians, and significant cost savings, which again will provide that ROI. So I think we all agree it's the right thing to do. I think your country is in a place where it can actually be successful, as opposed to my country, where the only way we're going to solve the issue is through pure competition, having the insurers who are now becoming providers compete against the providers who are now starting to become insurers. I think you could actually do it on a national level. You have a national EHR, which is fantastic. And if you can provide that bridge funding, I think there's probably a 3 to 7 year payback.
Thank you, Robert. I think that's very insightful for us to think about as well. Let me follow up with the next question. What are some of the foundational IT capabilities you think organizations should equip themselves with as they start on this journey for greater value capture?
So absolutely, the electronic health record is critical to success. And I know it's it's not just enough to implement the system. It's important that there's good hygiene around the system. So all the functionality of the system, all the data capture that's available to you in the EHR, it's important that you take advantage of that. So whether it's the timestamps, understanding what's happening so you can get the full value in terms of quality and outcomes and consumption. Once you do that and you combine that with activity-based costing, and you can see actually what is the cost of healthcare, where am I efficient, where am I inefficient, which physicians individually are delivering great outcomes at a low price point, or even if they're delivering great outcomes at a higher price point, right? We want to pay for value. So we want to understand quality and outcomes. We want to understand the cost and the variation, and that provides us with the tools that we need to improve healthcare. better outcomes like in the CJR bundle that I talked about, better outcomes at a lower price point. But it's ensuring that you fully leverage the EHR and you have an activity-based costing system so that you can see, that you can understand, and that you can impact the consumption and utilization of resources by your physicians, who, again, ultimately, it's not about the CFO or the finance department, and it's not about the administrator at the hospital. It's the physicians that we need to build as a finance team, that we need to build the bonds with, to provide them the information that they need to make great decisions to deliver fantastic healthcare at a quality price point.
Thank you, Robert. I hope the audience have found his answers interesting and valuable. We have now come to the close of the session. Thank you for sharing with us, Robert. And to the audience, I also thank you for joining us. I will now hand over the time to our MC. Jason, please.
Thank you.